morning, everyone. All right. Thank you guys for waking up early. Thank you for coming to this session. My name's Matt Dacso, as it says up here, and I am an associate professor in internal medicine at UTMB, University of Texas Medical Branch, way in the tropical paradise down 45 of Galveston Island. And I feel very blessed to be here with you guys this morning, and I really appreciate the M3 conference for giving me the opportunity to come and talk to you this morning about this topic. It's a topic that's near and dear to my heart, and so with no further ado, I'm also the interim chair of our new Department of Global Health and Emerging Diseases in our new School of Public Health. So that should be something you should look into if you're interested in doing global health work. I wanted to start just a little bit about myself, and just because some of you actually I know, some of you I don't know. I live in Galveston. You can see here, beautiful, scenic Galveston Island. This was a day where the water was blue and not brownish. As some of you may know, we have the oldest medical school west of the Mississippi River, health science campus, 5 schools. All health sciences. Old red here featured as the oldest medical building in Texas. And then we have a very specific focus, a lot of folks working in emerging pathogens, so emerging diseases like Ebola and monkeypox and SARS-CoV-2. These are all diseases that people study in our Galveston National Lab, which is a facility that can study these things in high containment. And we always joke that Galveston is it was selected as the site for really one of only 2 of these that are based at universities because we're on an island. So just who knows if something got out of the lab, they just sort of close the causeway and then we're good to go. But that's never happened, and we're in good shape. This is a very safe and incredible facility on the island. So it's shaped a lot of the way that we do global health is focused on emerging pathogens. Prior to my coming back to UTMB, I did my medical school there. I lived in Botswana, Southern Africa. This is a landlocked country that is surrounded by South Africa and Zimbabwe and Zambia and Namibia. It's a beautiful country, incredible country. Most people know it because of its incredible wildlife, the 5-star resorts, the #1 ladies detective agency books. So it really got into to the popular world because of these things. It's a high middle income country. Really is one of these examples of a country that took its time from independence, a peaceful independence from Great Britain in the late 60s, found diamonds a year later, and then invested that money into infrastructure, roads and schools and healthcare, but also was a place where there was a huge problem with HIV. And so at the time that I went to go work there in 2009, they were in sort of the midst of the HIV pandemic. There was at its worst, there was 1 in 3 people in the country that were infected with HIV, and it was declared. In 2001, 2002, the then president Sir Festus Mogae, actually gave a very famous speech in the country, and he said, "We are on the verge of extinction," right? It was a call to action, and this is where we started to see investment. And actually on these curves, which are very far away with very tiny dates, but I can promise you that's what they say, that there was a time where the new HIV infections were going way, way up, and then because of the strength of the and vision of President Bush, George W. Bush at the time, introduced PEPFAR program, the President's Emergency Program for AIDS Relief, mobilized really the largest amount of U.S. support for global health that had ever happened in our history as a country, and started to turn the curve. And you can kind of sort of see what happens with new HIV infections there. AIDS-related deaths started to go down, and so I was there as part of a PEPFAR program. So you started to see the numbers of people living with HIV go up, and the number of people dying from HIV go down. So this was a really important program. I worked for a partnership between the University of Pennsylvania and Botswana and the Ministry of Health. It was formed in 2001. They worked in HIV/AIDS. They worked in tuberculosis, medical education. And so it was a really important partnership. It was a very meaningful partnership. And it was also involved in establishing some of the training programs for the country to train the workforce. Part of my job was going out and doing outreach, going to rural hospitals, seeing patients, trying to do bedside teaching, trying to decrease the amount of referrals. This country, I didn't mention, it's the size of Texas, but there's only 2.5 million people who live there. So people are very spread out. It's about 85% desert. So actually the name for the currency is pula, which means water, because water is so valuable in the desert. So we would go out to the desert, to rural hospitals. We would make rounds. We would do teaching. But a lot of my time was on the ward, so I did time in the hospital, made rounds, taught residents, taught medical officers, and really, just as much as I taught, I learned myself. I also learned about the power of relationships. And so pictured here, not the donkey, I had no relationship with the donkey, but I really learned that the world of service is small, and people who are called to serve are called in different ways. These two physicians that you see on the photo on the bottom, on the middle right there, they are from Cuba. So if you've worked anywhere around the world actually, but especially sub-Saharan Africa, much of the healthcare workforce, a lot of people from Cuba come to work, and they come, this is one of the biggest exports of the country of Cuba is healthcare workers, pharmacists, nurses, laboratory workers, physicians, people to come and help and take care of people, especially in areas where a lot of those services may not be available around the world. And these were two Cuban physicians that I had the privilege to work with. And I said, wow, we are, and where we would make rounds, and I would speak Spanish, and I'd say, we're here in the middle of Botswana, and we're speaking Spanish to each other. What a small world we all live in. So I came back to Galveston to run our global health program at UTMB. I've been there since 2011. We really tried, because of the time in Botswana, it taught me that, in order to do anything meaningful, you need to make relationships, and these have to be long-term relationships. Right? We can't just expect that everything is going to change if we come and fly in for a week or two and then go back home, right? We have to make the commitment as institutions to be able to go and make these long-term relationships, because that's the only way that the needle moves, right? That's the only way that we actually get anything done. So these were long-term collaborations. We work with many faith-based organizations because of it was just the relationships that were present. A number of our faculty, some of them were retired missionaries, and so they had relationships around the world, and we leveraged those relationships to engage students. And really the partnerships that we formed were rooted in this concepts of relationships, respect, integrity, and humility. And so what we were able to do is get students out in the field doing stuff, but not doing stuff that we wanted them to do. It was the stuff that our partners wanted them to do, right? Serving the needs of the partners, right? Because who knows the health needs of a community better? A guy who, lives in an air-conditioned office in Galveston, which we need year-round, or someone who has lived experience, who's actually in the field, who does this work day to day, right? We are the ones who should be listening. And so we wanted our students to learn that approach and to go and do and serve the needs of partners. And so these are some photos of students going and doing cool stuff around the world. And what we saw over those years, we kind of tracked some data, and these are just 5 years of data, but we saw a lot of our students start to go into primary care careers. So, whether it's because they came in loving primary care and then continued on that, or whether they were somehow inspired by our global health program to go into primary care. I'll take credit either way, but we really, we have a deficiency of primary care in Texas, and especially in the US. It's hard to find people who want to go into these careers, so we were really happy to see this program translate into gains for our community as well. Then something happened in 2020. You may have seen it. You may have heard a few things about it. But there was this global level 4 travel award, or travel advisory. So this was a problem for people who do global health because, you can do global health at home, but man, a lot of our work was traveling. And so this was the recommendation. You can't travel because of COVID-19. And actually, it was not a good time to travel, right? If you think about it, when we go and we work in countries around the world, it seems like we're there to serve and to help, but actually there's a lot of work and burden that it puts on people that we work with. They have to schlep us around, they have to make accommodations for us, we have to make sure we're safe. If we send students, there's about 10 pages of liability paperwork and stuff that, you have to go through with them. I mean, it's quite an operation. And so countries that were already under strain from COVID did not need our students or our faculty coming to do our short-term things, right? So this was actually okay, and we also needed to direct our efforts inward as well. We had quite an experience with COVID here in Texas. There we go. So this is what I did. I basically, like a lot of people who do global health, I went into the hospital, I did the clinics, I went and did, I've made bedside rounds and play with an N95 mask, for patients with TB. So this was going in an N95 mask, and PPE was not too much of a big departure. Probably over the 2 years that we had a COVID unit, I probably was on every 2 weeks out of every 6. These were our residents. Just really people stepped up at that time. And I also joined, we have an Ebola unit at UTMB. We're one of 10 regional treatment centers for emerging and special pathogens. So joined our biocontainment team so we could be ready for the next one. Really, this showed me, I think this was for many the first time that global had come home, right? That the international, these exotic diseases we think live over there, came to the United States, came to Canada, came to Western Europe. And who did better? Africa or the United States, right? Who did better, Kenya or Texas, in terms of mortality, in terms of morbidity, in terms of the effects of the pandemic? So actually, many countries that we consider low income, low middle income, under-resourced, did very well with the pandemic. They suffered and they had mortality, they had morbidity, but not nearly as much as we did here in the US and in Western Europe and high-income countries. So I think this was a lesson in humility for all of us. So what I want to do over the next, I'm going to keep an eye on time. They're very, very organized here. I don't know if you've noticed that. I think it's because Dr. Paul is a surgeon, so this is with surgical precision. I'm going to try to, in the next 30 minutes, I'm going to try to get through a lot of stuff. Because I gave a talk similar to this about 4 years ago here, and I think my perspective has evolved a little bit, and I want to share that with you. So I actually want to frame it in the era of pandemics, where we find ourselves right now. So we're sort of in this weird tale of, little mini surges of new variants, but we're kind of on the tail end of the pandemic, many think. We certainly are. None of it, a year ago, we would have been wearing masks in this room. We're not. And so there's a lot of things that are happening in this era of pandemics we can expect, and I want to convince you that we can expect that this is not going to be the last one that we're going to see in our generation. And not that it's a scare tactic, but this is just something we should acknowledge as part of the natural evolution of our species. I want us to talk a little bit about the opportunities for health system strengthening that have emerged from the pandemic, some real-world examples, collaborations between academic and faith-based institutions. So this is something that I know at UTMB we've known for a long time, that actually when we work closely with faith-based institutions, we can actually accomplish a lot together. But I think we saw, especially during the pandemic, academic and faith-based institutions come together, even locally, domestically, in our setting. And so this I think, gives us some other illustrative examples. And then talk about some pathways, and there's actually been some writing about this, so I'm not gonna bore you with a bunch of graphs and stuff, but I will try to do this with examples from the literature that people have written about this, that academics are thinking about this. So I come to a church and to this conference as a person from an academic side because I really do believe that these connections are how we're going to be able to move the needle on improving health and health equity around the world. So let me just frame the first part of the conversation by talking about pandemics. And I don't think I need to convince anybody that pandemics are a thing. This is very tiny, and I'm sorry that you are going to squint to read it, so put on your readers. You don't have to memorize anything on this slide. All I think that's important to know is that pandemics aren't new, right? But they are increasing. If you look kind of since 1980s, you start to see an increased frequency of emerging infectious disease pandemics, okay? We start to see things like HIV/AIDS that emerged. We see things like SARS-1, so SARS-1 emerged and become a global pandemic, H1N1, chikungunya, Zika virus, Ebola, right? I remember I had some colleagues from Kenya come to visit us during the Ebola outbreak in 2015, 2016, 2017 in West Africa. And I remember them saying, they came all the way from Kenya, and we were sitting and having a coffee, and they said, our friends told us, like, they said, why are you going to Texas? You know there's Ebola there. So this was when we had a couple of cases in Dallas and other parts of the state. So we also know pandemics are not a new thing. We've had our experiences with pandemics. Pandemic influenza, 1918, 1919. Plague in the 1600s, right? So this was the plague mask. This was in a time where we didn't have germ theory. We thought all of the pathogens were spread through the air, and so you see this guy. They would go into communities and they wouldn't want to touch people, so they had these special sticks to examine them, and then they had these masks with this long beak where they would put cloves in the end of the beak as a way to filter out whatever the badness was, because they thought everything was in the air. This is also just to show you, these little fluffy balls here are all kind of are pictures of pathogens, each size corresponding with the number of deaths, right? And this is starting from the times of, bubonic plague, the times of the Alexandrian plague. So I think this is just a great graphic representation of pandemics, that pandemics are a thing, pandemics are a part of human reality. So Tony Fauci and Dave Morans published this paper in 2021, and they used this word. I've come back to this, and I've used it a few times. That we have entered an era of pandemics. And in this paper, it's a very good paper, they go through this history, this long lineage. They say there's a lot of things. They say something really important. They say there is nothing, I'm going to keep squinting around, but there's nothing new about this situation except that we now live in a human-dominated world in which our increasingly extreme alterations of the environment induce increasingly extreme backlashes from nature. So things are always evolving, okay, in our society, our relationships with animals, our relationship with the environment, what we do to the environment, what it does to animal populations, pushing them together, making them exchange pathogens more than allowing those to spill over into us. This is just part of the process. Okay? So I'm not saying it's a great thing, but it's kind of part of the human existence. So we know that epidemics emerge because we have global interconnectedness, human-animal migration, right? We have profound, and it's not, you can't build a wall or a fence high enough to keep out pathogens, okay? Humans, just like any other species, are going to migrate when conditions become untoward. We can't ask humans to stay in a place that is becoming uninhabitable, right? We can't just say, just stay there. We can't do it, right? We have to acknowledge that humans, animals are going to migrate. Just like I used to live in Botswana, zebra and wildebeest would migrate across every time, and the weather started to change, and the food sources were going away. They had to leave, right? And that's what happens. We also know that increasing interaction of different animal species, if you've traveled anywhere in the world or you've worked on a farm, there's all these controls in place. I've learned so much from farmers about how they control livestock, because they have to keep these things separated, right? Because they know, farmers and the agricultural community, they know better than us as human clinicians how diseases spread between animals and why they spread. I'm going to go through a couple of examples that we're all experiencing right now, just of that. And then there's climate change and environmental degradation. So we do a lot of work in Peru. The Peruvian Amazon is the lungs of the world, right? But there's mining, there is deforestation, and these are big things, right? This is not just the lungs of the world, but this is where so much biodiversity is. And if we destroy those habitats, all of a sudden, those animals have nowhere to go, and then they end up spreading, end up in different populations and with the ability to spread diseases. And we know that the vast majority of diseases that have caused pandemics are coming from animals, right? So these are called zoonotic diseases. These are diseases that are circulating happily between animals, maybe causing problems, maybe not. And then because of a sequence of events, they're able to spill over and develop the ability to infect humans. Ebola, HIV, SARS-1, SARS-2, flu. You can name any of the ones that you've heard on the news. They probably have their origins in an animal virus, okay? And so these are all very important things for us to acknowledge the interconnections. Ed Yong, he was a journalist for the Atlantic, published this paper. I really like this term. So you may have heard of the Anthropocene, which is sort of the era in which humans dominate the earth. So he makes an argument that we are starting to enter a pandemicene where pathogens and human-animal environmental interactions are dominating the earth, right? So it's our coexistence with these pathogens in our environment, in the animals, in the world in which we exist that is going to define how we live, right? And certainly we saw what happened to our population when we all went through the coronavirus pandemic together. So, and this just shows that SARS-CoV-2 has its origins in animal species. It's been well characterized. This was with 99.9% clarity that this was a bat coronavirus that was circulating happily. It found its way into an intermediate or another species to have developed the evolutions, and then we brought them all together in a wet market, and boom, here we are. So, you may, and you're never going to read that, but you may have heard of some of these viruses. Nipah virus making the news, SARS making the news, human monkeypox or Mpox now making the news, Zika virus made the news. All of these are called emerging pathogens, and they all have pandemic potential. And you can see this is a map with lots of little dots. And they're finding new ones every day. So this isn't like a scare thing. I'm not saying that now everybody has to become obsessively washing their hands and wearing a mask all the time. What I want to convince you of is that we are in this era, and it's what's important is for us to acknowledge it and then be able to engage with it. Because if we can acknowledge it, then we can prepare for it. So people may have tried to buy some eggs recently, and you probably have heard this story, but in the US, last year, we had the first strains of highly pathogenic avian influenza that were reported. And since then, there have been about 52 million birds that have died, either from infection or from culling. So when things are, when things are adverse and there's birds that are dying or poultry that's dying, you have to cull the whole flock. In 46 states. And the last time we had an outbreak like this in birds was about 50 million deaths in 21 states. So this is already worse than the 2015 the H5N1 outbreak. Interestingly, this hasn't meant that the egg industry is doing badly, all right? So some of the cost is because we're losing birds, but they're also they're doing a pretty good profit. So some of this is because of market demand. But we know that bird flu can spread between birds, between wild birds and domestic birds or poultry for agricultural use. And it spreads out there in between bird species, but it's very, very fatal. But it's also kind of difficult. We have not yet seen human-to-human transmission. We really just see the only case that's been articulated in the United States was in Colorado, and it was bird. It was a person working on a poultry farm, and it was bird to human. But there's this worry that because bird flu is so adaptive, because H5N1 is so good at changing its machinery, that it could evolve pandemic potential. So it's one of those that people are keeping an eye on. And we're seeing, actually, you may have seen the news about the minks, which are, people know them from the fur coats that we love to put on. They have mink farms, and there was a big outbreak of H5N1 among the minks. They had to cull the minks. There was just in Peru, there was a big sea lion outbreak. So it's actually in about 25 species now of mammals. And so that's why people are paying attention to it. Now, this isn't the first time that's happened, but it's just to show that these things are out there, we're watching for them, we're preparing for them, and that's the only way that we prepare during this era of pandemics. So what has the pandemic shown us about challenges? Well, it shows us a lot of limitations of our system. I think a lot of us who worked in healthcare during the pandemic, we felt like the public health infrastructure ended up unfunded or underfunded, that the kind of the for-profit model really was difficult. We had to have a lot of government programs to help people to get access to care when they needed it the most. We had a lot of issues with misinformation. People found stuff on the internet, and so it was a constant uphill battle to try to figure out what was true, what was real, and what was not. I had many conversations with my own patients in our clinic about questions related to COVID. There were also, it showed how many racial and ethnic disparities there are in the country. And so we know that there were worse outcomes among certain populations, especially lower income, or in Texas, Black and Hispanic populations that had worse outcomes from COVID than others. We also saw the power of social media, right? So many people using social media, but not always for good, right? Sometimes to spread things, and because we were worried, we're fearful, and so a lot of misinformation made it out into the world, and this caused like a double pandemic for healthcare providers, where we had a problem to fight the virus and then to fight the misinformation that was coming out about the virus. We also saw that high-income countries, in this opportunity, this really unique, once-in-a-generation opportunity to actually reach out to the world and share and improve lives and livelihoods around the world, we actually held on to a lot of stuff, right? We held on to patents, we held on to intellectual property, we held on to vaccines, we held on to therapeutics, right? We stockpiled them, right? There's this thing called the Strategic National Stockpile. We said, hey, we got to take care of America first. We've got to do it, right? For me, this was a yes-and situation. This was one of those ideas, this was one of those moments where we could have really brought vaccines to the world sooner. We could have brought therapeutics to the world sooner, but we didn't. And this is not just the United States. This is many high-income countries. And so you saw over the first months that vaccines were available, basically they were all going into the arms of people in the global north, right? They were not going into people in sub-Saharan Africa, in Latin America, in Southern Southeast Asia. So this I think exposed for us something that I think the faith-based community has known for a long time, which is that need is out there, right? And need is out there, and we can do something about it. And also, the vaccine industry did very well. Pfizer did very well on the vaccine. So we kind of see all of these things interrelated. So we have to embrace some difficult realities, I think, as we talk about this conversation about how are we coming together, how are we working together, is that global interconnectedness of humans and animals and the environment is the nature of the beast. That we have to kind of exit our echo chambers, and that's on everywhere, that we have to engage and meet people where they are, even if we disagree. And then, our way, and I'm going to say from the U.S. side, our way is not always the best way. We have to learn from other countries' systems and experiences. I went to Kenya recently, and I had conversations with some of our partners there, and I was just astounded. They said, here's what we did to control the virus, and here's what we did in the population. Here was this informational campaign we did. And I said, man, why didn't we think of that, right? I mean, so we can learn so much if we listen and open ourselves to others. Because really it's on us if history repeats itself. If we have this type of outcome again, this quote I've heard it 100 different times from 100 different people, but it's generally accredited to this guy, Dr. Paul Batalden from the Institute for Healthcare Improvement. And he says every system is perfectly designed to get the results it gets. So if we are in a system in which 1 million plus have died from a virus, it's because a system has decided that it is so, right? And so we are the architects of that system. We are the ones who can change it. So let's talk about systems just for a second. This is the Sustainable Development Goals. United Nations came together and they had the Millennium Development Goals. We got to 2015 when they were supposed to be done. They said, 8 goals wasn't enough. We need 17. So they went back into the workshop and they came up with all these metrics. And number 3 there is good health and well-being for all. So when we talk about health systems and how we can work together, I think one of the problems is that I think both on the clinical side and sometimes even on the church or faith-based side, we think that it's the end user, right? It's about going and providing care to that one person. But strengthening the health system has this potential to impact thousands, millions. And that's in so many different ways. Health infrastructure, medical products, workforce training, governance, right? Policy. There's so many ways that we can engage. So those are called the building blocks of the healthcare system or of the health system, because it's not just about care, it's about the environment in which people are allowed to be sick or not, or in which they make the decisions that sculpt their ability to be healthy or not. So what is the health system outputs? Are access to services, quality of services, demand, and then resilience. And what are the outcomes that we look at? Are coverage, so universal health coverage, so this is essential services, and then other types of interventions, poverty, nutrition, education. We often think health is healthcare, but health is all these things, right? Education, nutrition, and you guys, in the mission community and faith-based community, you know that better than anybody. Because the ultimate goal is healthy lives and well-being for all. So, how do we frame these things? I'm actually going to skip over that. We know that there are a number of challenges in this era of pandemics. COVID, mental health, climate change, cardiovascular disease, respiratory infections, dementia, aging. It almost seems unsurmountable. But I really do believe that if we form very good relationships and alliances, we can do it together. Because what ends up happening is instead of working together, we form silos, right? And I'm not talking between academic and faith-based organizations. I'm talking about even in academics or even in global health. We've got the malaria people and the TB people and the HIV people, and they don't necessarily all work together. So vertical programs, because of where the money comes from, results in these silos. We need much better collaboration intersectorally and funding for coordination of these health system strengthening programs. There's also a problem of the securitization of health, where we look at everything as a threat, right? Where we see these are threats out there and we have to prepare. It's like militaristic, like that we have to shore up our defenses. In an emergency, yes, right? But in general, like poverty, education, nutrition, that there's no way we talk about those in terms of security. We talk about those in terms of rights, in terms of the ability of everybody to have the same quality of life, no matter of where you live in the world. So let's kind of take it to the last part of the talk, talking about collaborations, because I've been working in this area for a long time now. And I think the first thing we have to say is that when we do any kind of work, especially around the world, coming from a high-income country, we have to acknowledge the colonial legacy, right? There's things that we are walking into that were set up hundreds of years ago, right? Expectations or political situations, racial disparities. A lot of these things were set up by colonial legacies. And they were set up by people who lived and died before we were ever on this planet, right? But they created a situation in which there may be distrust, right? There may be difficulty engaging because for many years, Africa, Latin America were seen as places to extract things rather than to provide things or to strengthen or to partner. And that didn't necessarily change in the modern era when we started to have, World Bank, International Monetary Fund, really big financial type focused development programs that also did not necessarily empower and capacitate partners in these low and underserved countries. They were structurally made impoverished by these colonial legacies. And now it's us. Now it's academics. So when I go and work and the question is not, well, what kind of research can we do together? It's, are you going to take data from me? Are you going to extract samples and then go publish papers, right? So these are all things that I think we have to acknowledge we're walking into. Missions are popular, all right? Mission trips are super popular. There's about 1.6 million volunteer tourists a year, 2 billion in the industry, 500 organizations that spend $250 million a year, and that's between faith-based and non-faith-based organization. And this makes sense because about 84% of the world's population would be called religiously affiliated. It's not different on the side of healthcare systems and academic health science systems. About 1 in every 3 medical students, talking pre-COVID numbers, participating in an international elective during medical school. There's huge demand for these international experiences, and there's real opportunities for research, not just for research purposes, but research that has a global impact. And so there's been a lot of investment in academic partnerships. So there's been a lot of scrutiny on what those partnerships look like. I really like these guidelines. They were published by the Working Group on Ethics and Global Health Training. They said, if you're going to send students, or you're going to send trainees into the field, shouldn't we actually come to some consensus with people who live in the field and live in these countries about their conduct, about how they should behave, about who should fund them, who's going to support them. So they come with a few main takeaways. It's actually not a long read. It's about a 4 or 5 page paper, but very packed. The emphasis on mutual benefit, the focus on equity, right? The idea that, okay, irrespective of colonialism and all the stuff that came before our time, can we not just acknowledge that there are haves and have-nots, and that we're all here because that's not a good thing? We don't like that, right? I always tell the students, if you're in a room teaching or learning about global health and you don't believe that everybody deserves the right to be healthy or a right to have an education or the right to, to have the freedom to vote and participate in democracy and all these great things that we love, why are you doing global health, right? That's what it's all about. So the focus from these guidelines is on equity, involving local partners, setting very clear goals and expectations, and then recommendations. They make very, very concrete recommendations for what they call sending institutions. So you're a university, you want to send students to go do stuff. You are a recipient institution, but also expectations on the trainees. Here's what you should know. Here's the code of conduct. Here's what you should and shouldn't do. And then sponsors. Now, there's a lot of controversies around short-term trips, whether you're coming from the mission side or you're coming from the academic side. The scope of work, who's supervising. Is this an appropriate scope of work? Should everybody be able to do everything, right? Just because we come from a high-income country, should we all be able to participate in healthcare, right? Even if we haven't been trained in healthcare. Who benefits? So are we benefiting more or are they benefiting more? The impact. So is this a program that's going to have an actual impact on the population? And then finally, is it going to potentially cause a burden, right? Could this engagement, could my students, my team of students, they've got to be schlepped around, there's got to be a transport, that means there's got to be a driver. That's a driver that can't drive maybe essential medicines out to a community because they're actually taking my students, to go have an experience, right? So the potential burden and then the power dynamics, right? So, and the vulnerability of populations. Sometimes people don't know or acknowledge that. And I find that when we balance these things, you see on the academic side, we are looking at like student opportunities, research, publications, prestige, promotion. There's a lot of things in the academic side that kind of help us gravitate towards this work, sort of the things that bring positivity or reward for engaging in this work. And on the faith-based side, it's evangelism. It's being able to spread the word. It's being able to minister. It's being able to do service. It's being able to volunteer, mobilize volunteers, mobilize youth. Youth engagement is so important in churches, and so many youth want to go out in the world, and they want to see, and they want to do something. And so I think there's a lot of pressure on faith-based organizations to create and provide those opportunities for youth. But I think we agree. We all want to address health. We want to improve it. We want to address inequities, and we want to advocate. We want to advocate especially for the poorest in the world. And we can learn from each other. So I think on the academic side, there's things we do well. There's a lot of things we don't do well. But there's a lot of things we do well. We do research, right? We help a lot of our partnerships. We work with them to do research. But research that helps those partners serve their communities, help those partners do the important work that they do in the field. We can disseminate. We can take that data, take that information, and publish it and bring it to the world and say, look at this example of what's happening in rural Kenya. Look, can't you apply this in Indonesia? Right? Are there lessons we can learn? Right? This is a way that we can that I think we can be good partners. Education and training, like institutes of higher education are training institutions. So this is what we do. We train people, and we train future generations. And so, do we want to continuously live in a world of servitude where people from high-income countries are going to have to come and do things in low, middle-income countries? No, we don't want that. Nobody wants that, especially people who are living in those settings. What they really are desperate for is more training opportunities. So we can partner with institutions in low, middle-income countries and global south institutions to give opportunities for training, for education, for capacity strengthening. And then we also are somewhat adept with engaging in policymakers, some institutions better than others. What about the faith-based side? I mean, I think, first of all, faith-based organizations have my gratitude and respect for the work that they do, because I think they have the power of mobilizing and sending a message through philanthropy. They raise money, and they raise it for good things, and they put it into things that grants and governments don't like spending money on, right? A lot of people don't like spending money on infrastructure, staff housing in mission hospitals. These are things that are essential for these hospitals or for these organizations to do the work that they do, but it's hard to find the money for that, and faith-based organizations are very good at doing that. Faith-based organizations make long-term commitments to communities. Faith-based organizations build trust with the communities that they work with, and they focus on relationships, and they develop values-based partnerships. And these are things I think we can learn from faith-based organizations. So we've done a few things with UTMB. I won't bore you with all the details. We work with mission hospitals in Kenya, Uganda. We've done project work. We've done community engagement work, all trying to address root causes of poverty. So what can we do? So this is kind of this is going to take us to the Q&A. I think the first thing we can do is, as we re-engage kind of in this, as travel's opening up and people are starting to get out, we start asking the questions. What do you need from us, right? What do you expect to gain from interacting with us, right? What is your hope from this partnership? What is it you would like from us? How is my organization going to benefit your organization? If we're going to turn the tide on inequity, those are the questions we have to ask. What do you want from us? Right? How can we serve you? How can we partner with you? Okay? And what are the potential what am I not thinking of when I am going to send a team, or when I'm going to send students, or when we're going to have a faculty come and do some work? What are the potential burdens that we are that need to be addressed before we do this? So I think this is a moment where we can really create a punctuation mark and start to have those conversations. I think there's been guidelines written about this. I won't bore you with all the details. But this was a really nice paper that was published in The Lancet in 2015 about kind of like straddling this divide between public health and faith-based organizations. And so building core competencies, appreciating everybody's objectives, increasing investments, and use good business models. But, on the bottom side, I like number 5 a lot, because number 5 says, do not use religious teaching to undermine evidence-informed public health practice, or use secularist ideology to undermine faith-based groups' work in health, right? That's, for me, very important, right? Because there is no reason that on the secular or academic side we should be undermining anything you're doing, right? No reason, right? At the same time, we think, I have seen the best examples, both internationally and domestically, when faith-based and academic organizations work together to share a common language and come up with science or evidence-based solutions that, and to communicate that to populations that may be mistrustful or that may not be sure. I mean, faith-based organizations have cachet, they have investment, they have the trust of communities, and that's something that we should appreciate and we should be partnering with organizations to do. So for academic side, I'm coming to the Q&A, we should be good partners, which means that we should focus on relationships and we should make long-term commitments to strengthening health systems rather than grant-oriented and time-limited ones. This is a big problem, that a lot of our funding comes from these short time-limited grants. So we're studying HIV, then the funding shifts to cancer, then we're studying cancer. We need to focus on building the relationships and the workforce and the trust. And that's something we can learn from faith-based communities. We need to collaborate better with faith-based organizations to develop programs that strengthen health systems so we can help, right? Pivot the language from, let's get out of the community and do things to let's figure out a partnership where we're thinking about a program that actually strengthens and makes more resilient the health system and improves the population health. And then encouraging the use of research to drive program growth and development around the world. For faith-based organizations, I'm in no platform to make suggestions, but these are just some academic suggestions. So take them with however big of a grain of salt. So I think faith-based organizations, you develop long-term collaborations so well, but responding to partners' identified needs and then aligning with health system priorities. If you can frame the work in national, international health system priorities, it strengthens the potential impact. Opening up to collaborations with academic institutions and seek joint philanthropic support. So saying, we want to serve our community and we think we can do it in these ways. What do you think? And we can come together and come up with really, I think, very creative solutions on how to have a true impact on health. I think we should be promoting the application of evidence-based medicine in public health interventions and encouraging trust within the communities. Say, we're doing our very best. Nobody's going to say they have the 100% answer on things, and nor should they. Science changes, all right? If we're being good scientists, then we're always changing, which is really tough and very frustrating for communities because they say, yeah, but 2 months ago you said we shouldn't do this. Now you're saying we should do this? I mean, the world is littered with those examples. Estrogen, aspirin, masking, vaccines, whatever you want to say. The evidence is always shifting, and for being good scientists, we are being open and transparent and having good conversations with everybody about them. And then mobilizing support for programs and projects that fall through gaps in funding. So this is something I think faith-based organizations do very, very well. We work with African Mission Healthcare, run by Dr. John Fielder, a good friend. He's actually one of our part-time faculty in internal medicine. And I love what they do because they work with these frontline rural hospitals, mission hospitals, and they do stuff that they're installing an oxygen plant at the hospital we work with in Mahua, right? Because they noticed just how much respiratory care depends on having oxygen and how hard it is to get oxygen out there. There's not an NIH grant that's going to pay for an oxygen facility, right? That has to come from people who believe in the mission and in the organizations. So, things we can both do, build partnerships. Let's not just serve, let's be of service. Let's keep equity as the North Star. Let's integrate training and capacity strengthening into initiatives. Let's focus on strengthening health systems to improve the lives of those most in need. And then I think we can think and act globally and locally. People always say, think globally, act locally, or think locally, act globally. I think we can do both. So we have much more in common than we think. I end with this. As I was preparing for this, I found a pastor named Josh Hunt. And and you may know him or have read his teachings, but he says, suffering is a universal language. Tears are the same for Jews or Muslims or Christians, for white or black or brown, for children or adults or the elderly. When life hurts and our dreams fade, we may express our anguish in different ways, but each one of us knows the sting of pain and heartache, disease and disaster, trials and suffering. Truly, suffering is the common thread in all of our garments. And I love that language, right? I'm Jewish, okay? And I've been doing this work, and this resonated with me because here are some Old Testament concepts, right, from my 5 books, okay? So tzedakah, which comes from the word tzedek, which means justice. Okay, this is a very important point. This brings us together. Gimilut chasadim, which is the giving of loving kindness to others. Jews serve others, right? Because we are giving others, we are giving to others, and we are giving to others in our communities. And then tikkun olam, which I think is maybe the most important one. You hear a lot of scholars talk about tikkun olam, which is about fixing or repairing the world. These are fundamental concepts, and that they unite us. They unite us whether we're Jews or Muslims or Christians, whether we work for faith-based or academic organizations. So I made it right on time. I think they're going to make me stop. So thank you, guys.